as a voice coach, I recognize that it's important for us all to speak and say how we feel and also be given the opportunity to speak and speak well.
We're heading really quickly into our first session for the morning, and we're looking at building resilient and equitable national health systems. Of course, we know throughout the Commonwealth, throughout the world, COVID-19 laid bare a lot of healthcare systems. And when you look across capacity and international systems and institutions, they were all brought to their knees. So what we want to talk about today is what role should or could international institutions, including the Commonwealth, play, and how can we work to advance universal health coverage, which is critical as a fundamental component to the right of health. So, I'd like to invite our moderator for this particular session, that is Dr. Inez Hassan, and she's a senior policy researcher at the Global Health Governance Program at the Usher Institute, and that is the University of Edinburgh. Round of applause for her. She makes her way up, looking lovely in white. Joining her on stage, we also have Dr. Justin Kunin, and he's a co-chair of the UHC 2030 International Multi-Stakeholder Partnership for Universal Health Coverage. He's also the co-chair of the WHO Social Participation Technical Network and SDG 3 Global Action Plan Civil Society Advisory Group. Round of applause for him. We also have Professor Sanait Fiseha, who is a globally recognized leader in reproductive health and rights, an attorney, a physician, and currently serves as the director of global programs at the Susan Thompson Buffett Foundation, as well as chief advisor to the Director General of the World Health Organization. Thank you so much for joining us, Professor. And last but not least, yes, round of applause. We have Dr. Ravi Ranan Elia, a physician and economist, a Cambridge and Harvard graduate. My goodness, am I even worthy to introduce you, sir? Welcome to the panel. And from 1997, he established and developed the leading health economics research group in Sri Lanka at the Institute of Policy Studies before transforming it into the fully fledged independent research center. Round of applause for this hefty panel as they get into the discussion. Inez, floor is yours.
Working? Can you hear me? Yeah. Fantastic. Ite Murahu. Is that correct? Good morning to everyone who's lucky enough to be in the room with us today, and good afternoon, good evening to those of you who are joining us online and from across the world. I'm delighted to be here, and I'm delighted to be able to moderate this session titled Building Resilient and Equitable Health Systems Across the Commonwealth. Before we get started, by the term health systems, because we're going to be using it a lot today, we mean the building blocks that make up healthcare delivery. So this encompasses the people, the institutions, whether they're public or private, the resources, all involved in the provision of health services in any country. And this is really a timely and much needed conversation because the COVID-19 pandemic, as we've all experienced, has exposed or further magnified many of the weaknesses that exist in our health systems. And especially important in the progress that we've been trying to make them more equitable and accessible for everybody. But also, on a positive note, the pandemic has surprised us with the rapid technology advancement and has shown us just what can be achieved with the right financing and political will. So there is hope. And so I believe this provides us with a unique opportunity to almost press reset and reimagine a different future for our health systems. So today, we will be reflecting on many of the lessons that the pandemic has taught us about the resilience of our current health systems and how they can and should be further strengthened to serve the public better. Also to highlight any success stories, because there have been many in fact. And we're also going to discuss the progress made so far towards achieving universal healthcare coverage, one of the key SDG targets that was set in 2015. And we'll define and talk a little bit more about what we mean by that a bit later on. Of course, this is the People's Forum, and so we're going to spend some time considering the role of civil society and how they can help progress towards universal healthcare coverage and deliver better health care services as well. And then finally, we're going to use this unique forum to consider the role of the Commonwealth and how it can be used, discuss how it can be used to build more resilient and equitable health systems, and more importantly, what the priorities should be for this unique group of Commonwealth countries. And so, without further ado, I'm delighted to turn to our esteemed panelists, Professor Sinait, Dr. Justin, and Dr. Ravi. And I'll be referring to you in those terms later on. Okay, so let's get started. The first discussion we're going to have is, as I've mentioned, about what the pandemic has taught us, about what is needed to support strong, resilient, and equitable health systems. So, like I mentioned, across the world throughout the pandemic, we saw kind of many issues. And I thought that there were many common themes that emerged, whether it was in developing countries or low-income countries, such as, for example, healthcare worker burnout, inequality in exposure, incidence and severity of disease. Some groups were more impacted than others. The reduction in access to certain health services, and sometimes the prioritization of health security over other areas. So my first question, I'm going to turn to Professor Justin and ask, what did the pandemic teach us about health systems and our ability to achieve true universal health coverage for all, despite the government's commitments to do so? And before you get started, I would be grateful if you could define universal health coverage for everybody as well.
Thanks so much, Ines. Muraho, wonderful to see everyone. I was last in Kigali just before the pandemic, and after all that we've been through, it's fantastic that we can all be together in person. So very grateful to be here. I'm really excited that we're talking about universal health coverage and health systems because so much of the focus on the pandemic response has been in a very narrow global health security lens. I'll talk about that in a minute, but you asked me to say what universal health coverage is. At its simplest, what it means is that all people everywhere should have access to essential, good quality health services, and those should not put them under financial hardship. So there are two wings to universal health coverage. It's about service coverage, what people get, and also this idea of avoiding financial hardship, because we don't want to make people poor to access health services. Digging a little deeper, we often talk about a cube of universal health coverage, and I wish I had a diagram, so I'll just use my fingers. But we talk about three axes, and on the one axis is who gets treated. So this is a question of equity. Are we really covering all populations, all people? Obviously, that's not always possible, but we need to go as far as we can. Along another axis is what gets covered. So which are the services that get covered? Obviously, every government has some constraints around their resources, so we need to prioritize. And then the third dimension, the third axis of the cube, is how it gets covered. How does it get paid for? Health financing. And often when people talk about universal health coverage, they're really only talking about this third dimension. So universal health coverage gets reduced to discussions about national health insurance. Now, national health insurance is important, but it's really important that we don't forget the service coverage and the equity dimensions. And so that's the overall scope. I can say more in a minute, but your other question was, what have we learned from the pandemic? And as I alluded to in my very first remarks, there has been naturally a really close and clear focus on global health security, on surveillance systems, on laboratories, on emerging infectious diseases. And that's critical and important, but I think what we've learned is that it's not enough, because unless you have well-functioning health systems, unless you have properly functioning supply chains, unless you have community health workers well paid and supported, unless you have community engagement, all of these efforts to put an end to emergent infectious disease threats fall flat. So I think in one sentence, what we've learnt is that there can be no global health security, there can be no pandemic preparedness without universal health coverage.
Thank you very much. Professor Sinait, can you tell us a little bit about what the pandemic has taught us about the role of government in delivering equitable national health systems and universal health coverage, and perhaps draw on some examples in your areas of work?
Sure, thank you, Moramutse. So for those of you who don't know me, I'm Ethiopian by birth. I say I'm American by chance and Rwandan by choice. So I'm really happy to be here. So as my compatriot, colleague and friend, Dr. Tedros says, universal health care and global health security or health preparedness are two sides of the same coins. Absolutely, we've learned a lot, and I will build on what has been said. The pandemic has taught us a lot, and for someone who's lived in the United States for over 3 decades and moved here in the middle of the pandemic, I think there is fundamental shift globally post this pandemic, but what we're taking out of it also differs depending on your optics. So for someone who's in this continent, I cannot move on without commenting the two big things that we observed, and then I'll talk about the role of government. But the prominent thing that we took away is that while we all are for global collaboration, the very reason why we're here as part of the Commonwealth, the global system failed people, especially vulnerable, marginalized communities. People in sub-Saharan Africa were scrambling, for vaccines. So the system that we built to get commodities, health products, supply chain, the technical assistance that used to fly in to help us could no longer come. So for me, one of the biggest takeaway is that supply chain system we rely on is broken. The second is the failure of the institutions that were built to protect, to deliver for communities around the world, could not do it. So with that background, when you think about what do governments do, what are the lessons, how do we ensure? For me, the biggest lesson out of that is while global coordination and institutions are incredible and we are part of a global family and the SDGs pull us together, at the end of the day, services are delivered locally. And what we have seen with the pandemic, especially in this continent, is institutions like African Union and African CDC really stepped up to pull their act together in an unprecedented way to fight an institution so that we are no longer at the mercy of donors. So having said that, what can governments do, right? Unfortunately, health for so long has been looked at something that you sort of kind of on the side, right? What this pandemic made clear is that you cannot neglect health and expect to continue business and other forms of things as usual. So I think governments do need to prioritize healthcare and healthcare investments. So really looking at the lens of, investing in health is investing in communities, investing in people. We need increased investments, particularly domestic investments. While the system is built, especially again, if you look at health in the global south, Africans got together a while back and made a declaration, the Abuja Declaration, to increase 15% of our GDP into health. Only 2 countries, as far as I know, sub-Saharan Africa, Rwanda and South Africa, do that. Many of us are investing very small amounts. So how do we increase domestic resources to ensure we have a very strong primary healthcare system? As my colleague talks about, we either tend to focus on global health security and forget basic, inclusive, essential health services, or in our part of the world, very siloed vertical systems. Because donors come with their priority area, and it's absolutely critical to prioritize, but people are more than their body parts, right? So ensuring that basic essential services are integrated into primary health care. If we look at the lessons of Ebola, the countries that did really well, like Ghana and Senegal, are the countries that had a very strong primary healthcare system. So I would say, I think governments need to increase investments, domestic resources. We need to look at local solutions. You talked about examples. The focus and again, the promotion tend to be around tertiary care. But if you see countries like Rwanda, for example, Operation Saving Lives, where primary healthcare, general doctors were linked to community health workers so that all primary screening was done at the community level, and it not only took services to the community, but prevented hospitals from being crowded and got timely service. So that's how Rwanda has managed. So for me, a very strong primary healthcare system, local solutions, including local manufacturing, and a very centered, integrated primary healthcare should be the way forward.
Fantastic. So Dr. Ravi, Professor Senait already mentioned a bit about financing mechanisms. I wonder if you can expand on that a little bit. And tell us about what we need to do more to improve the financing of UHC and perhaps kind of just specifically lessons from the pandemic as well, how we can finance our health systems a bit better.
Sure, thank you. And good morning, everyone. This is actually my first time in Rwanda, so I'm very happy to be here. And also, first time I've been abroad on business travel for 3 years, so very glad to be here in person with everyone at a meeting. It's not something we've been doing for a long time. Just to get back to your question, I mean, I think the importance of financing, I would say, goes back to, I think the word was already mentioned, solidarity. UHC is about solidarity, and the reason that some countries struggle with UHC is because they fail to realize that concept. And in financing, that's where you find the concept. So in order to achieve UHC, the global experience, the global lesson after 200 years is you can't achieve it, and you can't build resilient health systems unless you use public financing. And that means government taxation or mandatory social insurance, which requires government intervention. Now, why is this a solidarity issue? It's a solidarity issue because both those things require you to take money from the better off to provide services for the vulnerable and worse off. It requires, in effect, the coercive action of the state. And that's an expression of social solidarity. So unless countries are willing to do that, they cannot achieve UHC. And then the other aspect of solidarity is that in many countries we say, oh, you know, everyone does have access to healthcare, but we know in reality the vulnerable, the marginalized don't. And I think health systems which emphasize the value of solidarity, they're much more sensitive to that, and they take much more action to address those gaps. Now, I know in the course of COVID, I think Justin also mentioned about global health security. The reality is, frankly, and I'll be completely honest, I'm a great advocate of UHC, but whether you had UHC before or not really did not predict how well you did on COVID. I mean, that was due to other decisions you made about the public health strategy. But once you had COVID and you had thousands or millions of people with the disease, people turning up in hospital or maybe not even getting to hospital, the health systems which were already resilient and valued UHC, they did better. And I'll give you an example of that. Sri Lanka and Malaysia, I think, two countries I know well, I think those countries did much better in looking after the worse off when the infection struck them. They did badly at preventing the infection, that's another story, but they did really well. And I know in Sri Lanka, our health ministry people really cared. They went out of their way without the politicians telling them. They're so indoctrinated to helping the poor that they went out of their way to figure things out. How do poor people get drugs in the middle of a lockdown? That was a big concern. So I think it's the values of solidarity and whether they're inculcated in your health system, and that really affected the way health systems responded to problems or even knew that there were problems.
I think we'll come back to that point a bit later on, because one of the things I keep hearing from people who work in government is that it's difficult they haven't always had the opportunity to learn lessons from other countries. So I love hearing these success stories, and we're only going to progress if we learn from each other in the kind of with these very specific examples. Professor Senait, I want to turn back to you and just ask you briefly about the broader social and economic determinants of health. So you've mentioned already primary care and how that was, and community care, and how that kind of helped prevent a lot of illness throughout the pandemic. What about kind of further up, the social determinants of health? Have you got some good examples or some ideas of where governments have focused on that and where you've seen, yes, I guess some successes perhaps as well?
No, absolutely. I mean, health is interlinked, right? You cannot look at health in isolation. And I think part of the biggest problem that we are seeing now is when we look at health, we are even further downstream and we look at curative services more so than prevention. So if you look at health holistically, you will look at what does it mean to be healthy, right? What does it mean to be healthy is not just to not have disease, but it has to have full fulfillment, right? It is to have food security. If you look at places where there is no food security, where you have stunting, where you have food shortage, I mean, you are going to be vulnerable to illnesses, housing. So if you look at all the social issues people deal with, these are interconnected. So you cannot look at health in isolation without looking at all the factors that contribute to, quote unquote, being healthy or doing well. So there are so many examples. For me, at the end of the day, it's about the value of life, right? So it is how society values, or in our continent, how governments put value. So the best example, as I said, I've been in Rwanda for the last couple of years, and I've just been in awe. I mean, you hear about Rwanda's governance and Rwanda's health system and Rwanda's, despite its limited resources. But the incredible thing about Rwanda is the value the government and the society puts on human life. For a nation that has witnessed the atrocities of the genocide against the Tutsis, the resolve now is that every life is valued and interconnected. So soon after I arrived, talk about examples, because there was aggressive testing throughout the last 2 years, and as cases rise, there was significant lockdown. Of course, you look at it from civil liberties perspective, and somebody will say, oh, this is human right, how do you lock us up? But the truth is, your individual rights do get compromised when it becomes the well-being of society as a whole. But at the same time, Rwanda looked at and said, what are we doing to ensure people have access to food, right? So it wasn't only the government, it was the lesson of you are each other's keeper. So communities were contributing to provide food for those that were less fortunate in their own environment. Doctors, as I said, were going to communities. So for me, the biggest lessons from this pandemic, and also looking at communities that have done well, are the ones that really focus at the community level and flip this provider-receiver model of health-seeking behavior, not one that expects a person to get sick and then show up at a facility, but how do you go to communities and connect this issue and make sure? Ethiopia is another great example, the community health worker program in Ethiopia, where a person with a 12th grade education was educated to not only take care of health, but look at communities, make sure people are hand washing, they're using latrine, they're preventing themselves from malaria by distributing bed nets, food distribution. So when you integrate and look at all the components of what communities need, that is really how you get to health and well-being, and not just by availing health services alone. And frankly, the focus on prevention, more so than just focusing on treatment.
Absolutely. I mean, we could discuss this for a lot longer. Unfortunately, we have to move to the next session. This, of course, is the People's Forum. So we're going to now have a little bit of discussion about what civil society can do. So I'm going to turn to you, Professor Justin, and ask you a bit more about what do you think that civil society groups can do. There's many groups have been advocating for universal health coverage for a long time now. So how can they have a greater voice in pushing for UHC? Have you got specific ideas about what they could focus on or do?
I'll say something general and then I'll say something specific. First of all, if you think about what's the theory of change when we want to introduce universal health coverage globally, what do we do at that? On the first level, people think, that there's these big global discussions. We go to high-level meetings in New York, and these are important, and all of the world's leaders, well, many of them turn up, all of them tend to sign these declarations promising universal health coverage. And in a way, that's important because it does showcase on a global scale what individual governments have committed to do. But ultimately, heads of state and governments are not accountable to these global processes. They're accountable to the people who live in their countries. And so bottom-up accountability is at least as important as what happens in New York and Geneva. And so it's critical that civil society is there asking for these reforms in each of our countries, because that is where the pressure comes from. So I think civil society has a critical role to play in asking governments for the version of universal health coverage that we as communities also want. I also think, as Professor Senate pointed out, that civil society and communities have a key role in service provision because we like to say communities are the eyes and the ears of the health system. They are the people closest to the most vulnerable and most marginalised, and the people best able to provide the services needed in the language more broadly than just the spoken language, but the culture that affected communities needed. And we saw with the pandemic that when any one of us is vulnerable, when marginalised or vulnerable communities are particularly affected, we all become affected. So they have a critical role to play in providing services as well as this accountability process. In terms of something specific, and I can be a little bit partisan, but I know that there are some people in the room who might be interested, UHC 2030 is the international multi-stakeholder movement which coordinates advocacy towards universal health coverage. We have a civil society engagement mechanism, which is our civil society constituency, currently about 1,000 organizations in 100 countries. You should join, because that's how you find out what's happening among global discussions around civil society. So you can go to www.csemonline.net, become a member. It's free. We ask nothing of you, but that's how you get involved in the global conversation. Obviously, this is a huge global endeavor. It's not possible for any one organization to create universal health coverage for the world, but we all need to take little steps. So I'm suggesting something big and also a little step.
Thank you very much. Dr. Ravi, and what are your thoughts on civil society, and specifically, what is the key to successful partnerships with civil society and the private sector, in your view?
I think to a large extent I very much agree with what Justin already said, and I think there are two things there. One is, I think clearly at the local level, community-based organizations, that part of society, can play a role, particularly when health systems are dysfunctional, when there is no universal coverage. And I think that's important, it has to be done. But I'll be completely frank, ultimately it's a Band-Aid. If you want complete universal coverage, you need state action. And that's where I think the other role of civil society is important as an actor within a country to advocate for change. And I think that's what civil society should do internally. And I think also, as noted, what happens internationally at these meetings doesn't matter. You know, when our politicians go back to their countries, at least in my country, they don't really care what anyone thinks outside Sri Lanka, right? They only care about what voters and interests in Sri Lanka think. And so civil society is a part of that political dialogue. You need to be in there advocating for universal coverage. But one more thing I would say is even more critical. Why is it that so many countries talk about universal coverage but don't get there? It's because there's financing problem. And the financing challenge is hard. So I think what civil society really needs to do a lot better in most countries, including mine, is to advocate for taxation. Right? In most of the Commonwealth countries, we don't have insurance. We rely on taxation. You have to advocate for taxing rich people. Right? And this is absolutely critical. Right? Otherwise, Abuja Declaration was not successful because the governments went back and nobody held them to account. Unless we're willing to talk the uncomfortable truth that better off people, and I'll say this about Sri Lanka, we have this challenge. We have to get the better off to pay more in taxes because the elites do not want that. They'll talk about anything else under the sun, but not that issue. So I think civil society has to add its voice. And I'll give you one good example from the Commonwealth. I mean, it's not a country with a bad health system. This is the UK. A very interesting example. A few years ago, both political parties in the UK were saying we cannot spend more on the NHS. It's too expensive. We can't raise taxes. It's a recession. All spending anyway is frozen, right? This was, I think, the Cameron administration. And there was some action by trade unions, the British Medical Association and some other health unions. They went and did polling. And they polled the voters, and they found that British voters, whether they were Labour or Conservative, all said, we want the NHS to be stronger, and we are willing to pay higher taxes for that. And they took that evidence to the political parties, to the politicians, and in the midst, I think, of a recession, when spending was frozen, they got both parties to agree to an increase in taxation for the NHS, and health spending was increased. It was the only item of the budget that was increased at that time. So this is an example of civil society at its best. And that's what I would call for in your own countries. Don't look internationally.
Can I add a very quick comment on top of that? I'll be brief. Completely agree that there's a political issue around financing. You know, there's a a statement in the 2019 political declaration calling for all governments to increase public health spending on primary health care by 1% of GDP. That's bare minimum enough. And as you said, it must be through progressive taxation, and that's why it's difficult politically, but that's why civil society needs to be there. There's another political issue, which is around the equity question, because universal health coverage isn't universal health coverage if it doesn't apply to marginalized or vulnerable or populations we find it difficulty talking about. If we're not talking about prisoners and refugees, if we're not talking about LGBT people, if we provide healthcare service to everyone else, but not those people, that's not universal health coverage, and this is difficult for government. So civil society really needs to raise their voices, and they do, for these marginalized populations.
Absolutely. Professor Sinek, do you want to comment?
Sure, I think Justin raised it. Civil societies include a whole range of actors, but at the end of the day, it's we the people, right? Like the people in this room. And I think the incredible capacity and expectation is that we hold government accountable, right? As it's been said, it's very easy to go and pledge things at international meetings where there are photo opportunities and you look really good, but to come back and implement those at home can only be done through civil society. I'm enormously grateful for civil society in this continent because they have been the one fighting for the hardest issues for marginalized populations, women and girls, sexual and reproductive health services. Oftentimes, when governments shy away, raising all sorts of reasons, there have been people who have been willing to even take a bullet to fight for things they believe in, marching on the streets, holding local election, using their votes. And if we see one thing in this pandemic was, I don't think, especially when I was in the US, everybody talked about how somehow this pandemic came up and equality showed up. No, inequality was there, right? The pandemic just shone light on the deep, fragmented, broken system we have. And one of the things we saw was the disproportionate impact of COVID on women and girls. Everywhere in the world, not just in sub-Saharan Africa, increase in domestic violence when women are locked up with their abusers. Schools were shut down, and there was no safe place for girls to go. Disruption of essential services, prevented women and girls from accessing contraceptive services, PAC, safe abortion services, safe delivery, lack of supplies. So this was really tackled in many parts of the world by civil society. And I think civil society needs to continue to be a very strong voice for the people, holding government accountable on all issues that were raised in this room this morning.
And Professor Sinek, I also want to ask you, because you come from a donor's perspective, but you get work with governments, you work with civil society and many other actors as well. So when you're in that dynamic with all the kind of these different actors, and we know where kind of the power lies, obviously there'll be kind of the private sector as well. What are some of the barriers, do you think, to getting the voices heard from civil society, or what can they do differently from that perspective?
Yeah, I think a lot has changed, right? I mean, this talk started this morning about what are some of the shifts. And I think just a lot of things happened over the last 2.5 years. One of them is the inability, whether it's donors or international partners, to fly in or to be in podiums like this. Oftentimes we tend to dominate, we get the space. So what happened is this virtual space, this Zoom, just all of a sudden a lot of people from marginalized communities, people who normally will not be in the room, found themselves sitting among the most powerful and demanding their rights. And my biggest worry, frankly, when we start this convening, while it's amazing to see people face to face, is that will slide back, right? Because who gets invited to come is the connected, it's the leaders, it's not the everyday people. And I think one of the things that happened in these 2 years, people were calling out governments, they were calling out donors, they were calling out saying the status quo cannot continue. The flying in cannot continue, so you have to build local capacity. We need to strengthen local institutions. We can't rely on a system where most donors put their resources in institutions in Geneva and New York or London that fly in to either give technical assistance or to fly in commodities. So that demand, I think, needs to be upheld and need to be delivered on. And I think this is where, communities like this can play a huge role. We need to invest in local, I said civil society is a mixed bag. There is a whole range of civil societies. I think there is enormous need to strengthen local civil societies that are closest to the problems. While international collaborations are amazing, UHC 2030 is a great example where everyone is invited to come to the table. At times, you need to, figure out a way to strengthen, and I think donors, and especially bilateral donors, have huge responsibility in building the capacity of local groups and not making them an afterthought or a recipient of a sub-grant. So really what I'm hoping is that we spend a lot of our time and intentionally build local capacity, local groups, they have their voice, strengthen it, give them the tools so that they can hold governments accountable.
Absolutely, and that's our very next section. I'll come to you in 5. I mean, if you want to speak up now, feel free to.
Yeah, if I could have a mic.
Absolutely.
Yeah, my name's Richard Reason. I'm the General Secretary of the Commonwealth Disabled People's Forum. And while I agree that women and girls got the rough end of it, the people who died disproportionately were disabled people. The women and girls who got the most violence were disabled women and girls. And perhaps because you're all from a medical background, you have difficulties dealing with the concept of disability as a human rights issue. And I think that was one of the big mistakes of all the governments of the world, not to recognise us as a constituency who should be consulted and part of the solution rather than being seen as part of the problem. And there's nothing worse than the concept of calling us vulnerable to pandemic. No, we're at greater risk. We're not vulnerable. Vulnerable is an excuse for those who don't want to do anything. Vulnerable means, we can't do anything about it. Being at risk means that those with power and influence have to do something about it to reduce the risk. And I'm glad you praised the NHS, but equally, the highest fertility levels were in the UK during the pandemic, and it was quite obvious that putting people together in institutions, care homes, hospitals and so on, they were going to be higher at risk, and no at-risk strategies were put in place. In fact, the Secretaries of State just ignored it until more and more people died, so that in the UK, 2/3 of all those who died in the pandemics were disabled people. And this is outrageous human rights abuse, and I want to hear more about it from the panel, how we tackle this. And my suggestion is that we need to collaborate, that we need the people who are on the marginal side of things to actually be part of the solution and being part of what we need to do. Thank you.
I mean, I think we all fully agree. Does anyone want to comment? Would you like to comment?
Well, I completely agree. I think civil society, and I am a proud member of civil society and a community-based organisation myself, including working with people who live with disabilities. I think sometimes this discussion is framed as, well, we need to consult with civil society or we need to talk to civil society. No, actually communities need to be at the front and centre of the solution. And it's not always up to communities they shouldn't always have to advocate to be at the table. I think we also need to build capacity in government so that they know how to do it. Often governments, frankly, have no idea how to reach these communities. And so I think this is also about building capacity among governments to be much more inclusive. I know WHO has done a lot of work recently around social participation and developing institutionalized mechanisms for including communities. And those things need to be set up before a pandemic happens, because once it happens, it's too late. It happens now. So we've got another chance before the next one. But people like you need to be at the center of the conversation, not consulted on the sides.
Yeah. And sadly, I think it's a reflection of wider society that we don't see it as a priority. And as we spoke about earlier, it's a topic that's very close to my heart as well. Can you raise your hand if you have any questions? We're going to take questions from the audience now. So I think I'll just try and divide it up by where you're sitting in the room. So the gentleman in the orange top. And there are mics roaming around. I think someone will come to you.
Good morning. Clive Lawton here, Chief Executive of the Commonwealth Jewish Council. Well, my name already says something of this by virtue of the fact that we're council. It's a strange fact that of all the accredited organisations to the Commonwealth, other than Muslim Aid, we are the only organisation to be related to a religious community. And when this gentleman talks about encouraging civil society, for example, to lobby for raised taxation, or when you want to spread commitment to and enthusiasm for and take up of medical services, not least vaccinations and things of this sort, you have to get to the people. And religious communities are by far, and I'm not talking about Jews, there's only 10 of us, but religious communities, mosques, churches, gurdwaras, mandirs around the world are the places where not only do people go, but they can be influenced with the relevant messages. This is all about the ethics and morals of our society. If we're not talking to the religious leaders and encouraging the organizations to spread these messages, then it's not that nothing happens, something different happens, which frequently works against what we want to do. So failing to enlist religious is an extremely foolish thing to do. Governments fail continuously, civil society organizations fail continuously, and lobbying organizations fail continuously. And so we find ourselves, strangely, as the Commonwealth Jewish Council, lobbying on behalf of all religious communities, not just our own, because we're the only voice here that raises that issue.
That's a very good point. Thank you. Very good point. Especially in the area of misinformation, that we saw a lot of that around the pandemic, and actually oftentimes, where I can speak locally in London and UK, a lot of times religious leaders were the ones who could influence their communities to take vaccines and to get tested and all that. So very, very important. Again, anyone would like to comment? Dr. Ravi?
Yeah, no, I'd just like to, I completely agree with what you're saying. I mean, I'm a Christian, and I live in a multi-religious country. Christians in my country are a minority, so I don't normally talk about religion or religious belief in my work because of sensitivities. But the issue of social solidarity, about looking after the vulnerable or the worse off, that's fundamental to most religions. And as a Christian, and I know in Africa many of you are of belief, in Christianity, the most important message is love thy neighbor. And so for me as a professional, although I don't say this publicly, my commitment to UHC reflects my deep religious belief that we have to help those around us. That is what we are called here to do. And I think in Judaism, in Buddhism, in Islam, the same values are found expressed in different ways. And I think as civil society, in a democratic society, I think, yes, I agree with you, it is your role to translate those values into the governing system. Now, we cannot put, I would object to religion being in the Constitution or be part of the state. But to the extent that governments reflect the views and feelings of the people, civil society and religious organizations have an important message to play. And I would say also for UHC, I think religious organizations should take that as one of the things they should fight for, because it is fundamental to that, I think, our shared underlying religious values. Thank you.
Okay, thank you very much.
I think maybe if I can quickly build on what Ravi said. I mean, we've heard, for example, so far, issues of disability being raised, issues of religion being raised, right? So for me, when you center the work around community, you look at the issues in that community, and then you say, who are the people? I love the language of at risk or greater risk than vulnerability, right? And say, how do we pay attention to these groups? But oftentimes, whether it's governments or international partners, are so far removed from the community where policies are made, where decisions are made, and then somehow we sit year after year and wonder why we're failing in implementing. If you don't have the communities buy-in, if you don't have the communities who are actually, and earlier I talked about flipping that model of operator-receiver, who's giving and who's receiving, right? Like that needs to be flipped. And absolutely, I mean, if you look at sub-Saharan Africa, the informal authority lies within religious institutions. religious, Christian, Muslim, paganism, whatever you want to call it, traditional African religions, that's sort of where the authorities lie. Culture, looking at cultural sensitivity of what is accepted, putting the work in the context of the cultures of the community. So for me, when you center these things at the community level, you can find the answer and then empower communities, which literally is what civil society is all about, is the community. You find the answers for like the seemingly very complex questions that are really not that complex.
Brilliant, thank you very much. Okay, we'll take a question from this side. The gentleman with the hat.
Thank you. My name is Amir Kahlani Al-Sharabi, the Vice President of Commonwealth Jewish Council, Tanzania chapter. I fully concurred with Clive's who have said, and what the doctor have said. We may not, mostly in Jewish life, we don't promote religions, but during the epidemics, if religious were included in, then you would have known that you would have learned something. For example, in the Islam's faith and the Jewish faith, washing of hands is a regular basis. So you'll find that it will not have been complicated to encourage people to wash hands, because in Islam and Jewish, from the beginning of you waking up toward the evenings, washing a hand is part of the ritual. So civil society and the government should be always consultative with religious. For example, I'm a rabbi of the communities, and rabbis are not spiritual leaders, are teachers, and then you find that you know a lot of laws that will help. Secondly, local knowledge should be criminalized. For example, in Tanzania, during the time of the former president, due to reach of the science medicine, he tried to encourage people to use the local remedies. So I thought instead of the World Health Organization criminalizing what he was encouraging, they would have come to incorporate what are the local knowledge in science and how to improve to reach the more local grassroots. So I think both sites like an ecosystem, the government, so civil society, and the religious. Thank you.
Thank you very much.
Hello?
Yes.
Okay, perfect. Hi, everyone. Hi, panelists. This was an amazing, really an amazing session. My name is Shazia, and I'm the founder of an organization that is quite new, actually. It's called EJO Leaders. And the goal of EJO is really around identifying exceptional grassroots leaders and upskilling and building capacity to join government and influence policies. And the idea is to really focus on women, on youth, on rural communities that are underrepresented. So my question today really is around this, when we look at the pandemic, what we also saw is a failure of public leadership. And when we talk about, Professor Sanait, when you talk about how governments are struggling to connect with their people, that is a failure in public leadership, because there are people sitting in the room that are not representative of these grassroots communities and of communities in general. And so my question to you really is around what is the role of us in the room as civil society to ensure that our governments and people sitting in the room are actually representative. They're actually connected to grassroots communities that they're serving. And what is the role of us here to ensure that we have women representatives in government, we have youth representatives in government, because it's only if you have people that understand communities in the room that these people will go back to their communities and ensure the inclusiveness. And maybe if you can speak a bit about healthcare, if you have some examples around that importance of representation vis-a-vis healthcare. Thank you.
Thank you very much. Justin, would you like to comment?
Thanks. I think that's really critical point, and I might start at the end and talk about health and health services. 70% of the world's healthcare workers are female, and without the female healthcare workers during this pandemic, we would have been in a lot more of a problem than we already have been in. And do you know what percentage of leadership positions in health are held by females?
20%.
20. I thought it was 25%, but something like that. Clearly unrepresentative, and I think it's reflected in the decisions that have been made in many respects. And one particular example is around, I mean, this might sound like a silly example, but it's not, around PPE, around personal protective equipment. There's an initiative led by WHO, government of France and some others, around gender equal PPE, because who designed the PPE and who made the PPE? Men, and they didn't fit the female workers, and so they were, I mean, it sounds ridiculous, but it's critical that we have representation, and I think, thank you for particularly highlighting the issue around female participation. But if we don't have this participation in multilateral organizations, in governments, in all the places where we can be, we'll see the consequences that we've seen.
Do we have any civil society members who've had success in integrating with government and getting their voices heard? Any kind of success stories? Yeah, lady at the front. Oh, is there a mic? It's coming. Oh, thank you.
Thank you so much, sir. Thank you. Good morning, everybody. My name is Tandiwe Mfulo. I'm from Commonwealth Disabled People South Africa. So our success story in South Africa, it was our organization of Disabled People South Africa to be part of the team that is planning in terms of the COVID-19 and disasters. So we managed to reach a lot of people with disability in all provinces, in all 9 provinces, there in rural areas. That was a success story. But my question on this debate is to say, we've realized that when the pandemic comes in, there was a lot of challenges. What I don't see is to say, the system that I use, they are saying they're inclusive. But when I look at it and research on it, the inclusive of people with disabilities is not there. So I just wanted to find out from you at the panel to say, when you realize that some of the things are lacking, what plan was there? And my last issue is, all government of the Commonwealth have been, they ratified the UN CRGP. But for me, policies are good. In South Africa, we've got the best constitution in the whole world. Our constitution is so inclusive because as people with disability, we were part of the team. The only challenge is when I go around in all the countries of Commonwealth, the rights are not real. So it's time to make the rights real, meaning holding our government accountable when they come to CHOGMs or whatever they call it. First questions from whoever is there must ask them, are the rights of people with disability real? Are you implementing what you signed for? Yeah. Thank you so much.
Yeah. Thank you very much. Dr. Ravi, do you want to address that?
Sure. Can I also address the previous comment as well?
Of course.
Sure. Yeah, I think what this brings up is issues of accountability and representativeness, right? And failures or deficits in that. We all think it's a good thing, but it doesn't quite happen. And I'd like to just, because this is a Commonwealth meeting, right? This is a meeting of Commonwealth nations, and we share some things in common and some values in common. And I'd like to just share one experience from Sri Lanka, my own country. So Sri Lanka, it's a South Asian country, but for decades, we've had much better healthcare than the rest of South Asia. We have UHC. We're alone in the region in having UHC. And why is it that we have that? Well, it's very interesting. You have to go back 100 years. Back in the 1920s, there was a constitutional problem in Sri Lanka, and some people came from the UK. This is a Commonwealth story that I'm telling you. And they looked at the situation in Sri Lanka, and they said, look, the women are being ignored, and they're marginalized. That was the nature of our society at that time. The children are ignored. And there were lots of other vulnerable people, the poor in the working class in the urban areas. They were very deprived. Their housing conditions were bad. And what these people who came from the UK said, we need to solve this, but they didn't tell us to solve those problems. They only made one recommendation, which I'm always eternally grateful as a Sri Lankan citizen. They recommended that Sri Lanka should have self-government based on universal franchise, with women being given the vote on the same basis as men. This was in 1926. It was so radical, for those of you from the UK, British women had not yet voted in an election on the basis of universal franchise. So this was an incredible, radical piece of social engineering. And they had the foresight to understand that accountability in the long run mattered more. And that's why we ended up with our health system in Sri Lanka. Not because anybody told us to do better on health, because they gave women the vote. Now, things have not gone perfectly. We have problems, as you know, in Sri Lanka right now. So I think what that also points to is that there has to be further struggle to improve the quality of a democratic system, to improve accountability and representation, and that involves more than simply voting and having elected legislatures. So that's an ongoing struggle. And like UHC, people in UHC often say, it's the path to UHC, you can never get there. The idea there, it's a constant struggle. And I think within the Commonwealth, what I would say to everyone, there should always be this constant struggle to improve accountability and representation in our societies, and not just the formal structures, but civil society, as you mentioned, they also have a role to play. So that's what we need to do, improve the quality of our democratic systems.
Thank you very much. We've got some time for a few more questions, and then don't worry, there's going to be some more time at the end. I'll take someone from the back. I can see someone wearing red right at the back. Yes. Is there a mic?
Thank you very much. My name is Pauline Irungu. I'm from Nairobi, Kenya. I'm a member of the CSEM Advisory Group for Civil Society, and I'm really glad to be here. I just wanted to make some few additions to what Dr. Justin Koning said in terms of thinking about health systems and strengthening health systems. One thing I really do hope that we can take home from here as civil society and as the people who are very focused is how much is UHC centered on people, and how does people-centeredness play out within our own countries? I was really excited to hear Ravi's talk about accountability is at your level, at the country level. It's great to have global guidance, global agreements and commitments, but the reality is when you touch the ground in Nairobi or whichever place you live in. And I think coupled to that is, for me, civil society does need to look at, in addition to talking about accountability, ask yourself, accountability for what? It's many times I've seen our governments, we've been doing advocacy around health financing. Governments will write a budget. But what about execution of that budget, ensuring that resources flow to where the people are, and they're deployed to the right things, and then they are accounted back for? And resources in their entirety. It is money, it is human resources, it is equipment, it is commodities, it is the foot soldiers in terms of community health workers who will reach every mother, every child, every human person within their homes. And that, for me, the route to UHC must be cognizant of that. There is a component of UHC and accountability that we also need to be thinking about. How efficient and how much are we closing the gaps where leakages happen? And leakages of all sorts, whether it's money, whether it's opportunities, we also need to be thinking about that. And I think as a round off is the role that civil society can play in being an interlocutor between the political system and the health system. I've worked in that space. It's usually complex, but one thing I did learn, we expect our political leaders to deliver for us. Many times, they're not clear what it is we expect of them. And they're people's representatives in legislation and policy making. There is also such a gap between the political leadership and the health system that delivers services to the people and addresses people. So how do we play in between and ensure that these two are capacitated and we build a level of trust between them to be able to talk to each other? Because in many times, politicians will not be talking to civil society, and therefore it's important that we play in that space at all levels, from global to national and even to the subnational level. Thank you very much.
Thank you very much. We're going to move on now to our last section, and then we'll have more time for some questions at the end. So in this final section, we're going to talk about the role of the Commonwealth. So what can we do as a collective? How can we use this unique family and strengthen collaboration between countries to help meet these UHC goals and strengthen our health systems? And I know there's lots of work being done throughout the Commonwealth. For example, the COVID-19 open-ended informal technical working group, which helps to share knowledge and for networking and with focuses on certain diseases. But before we go to some of the questions I had sent earlier, based on the discussion we've had with the audience now, and this is for any of the panel members, what do you think that the Commonwealth can specifically do to try and help civil society organisations get inroads with governments and just to make some more progress? I don't know who wants to. Professor, would you like to take that?
I'm just going to build on a comment that was raised by a colleague who's training people to get into public sector. She talked about public leadership failure. I think that has been greatly, seen, observed during the pandemic. So I think there are opportunities to think about bringing, just sort of young people and preparing them for public leadership. I think is something to do. Inclusivity, I think that the vulnerable versus risk is just really resonating with me, because when we see risk, we mitigate risk. But when we see vulnerability, we leave it there, say, like a sort of to chance. So I think policy framing, inclusivity around all people, around policy, and also ensuring that we measure, right? Like measurement. I think measurement, what is, they say what's not counted does not count. And a lot of things are talked about, but are not counted. It's very easy to talk about financing. You can measure it. But my dilemma with UHC has been, there's all this global conversation or local conversation about UHC and leaving no one behind and whatever. And then you will go to an average health center, frankly, anywhere in the world, especially in the developing world. And people don't want to go there. They are not. I'm talking about people-centered. Women who are pregnant and show up are mistreated. They have no pain medicine for labor. You go, and people avoid health facilities because they don't get the quality care they deserve when they show up at this facility. So I think there needs to be as much emphasis on centering quality and centering it on the people. So are my quick reflections based on the conversations.
Thank you very much. Professor Justin, can you tell us a little bit more of what do you think about the role of the Commonwealth in echoing national calls for debt relief or reform of international laws such as the TRIPS waiver tax relief? Obviously, this was very pertinent throughout the pandemic.
Well, perhaps you're asking the wrong person because I'm not a financing expert, but if you think about the buckets, how does healthcare get paid for? Either it gets paid for by governments, and we've had a lot of discussion about this, or it gets paid for by overseas development assistance, or it gets paid for out of pocket. And so turning to those last two buckets, overseas development assistance really is it's incredibly important, but it's a drop in the ocean. It's 1% of global spending on health. And it has particular catalytic roles, but it's not the solution. It peaked in 2014 and it's plateauing at best now. Out-of-pocket expenditure is the thing that we want to stop happening, and we've done some since the turn of the millennium. We've done somewhat better on that, but we don't want it to go backwards. The remaining bucket is public financing that we've talked about, and yet we have this critical situation now where governments' budgets and finances, which were already stretched pre-pandemic, are now incredibly stretched. And so the World Bank did some work, and there's really a bifurcation. They looked at 126 countries in which GDP per capita by 26 would exceed 2019 levels. 52 countries home to 900 million people, where by 26, government budgets, GDP per, well, not government budget, but GDP per capita will not exceed 2019 levels because of the impact of the pandemic. So I think we need to recognize that resources are extremely strained at the moment, and therefore any avenue that's possible, whether it's debt relief, whether it's TRIPS waivers. So there is, was in March this year, some version of an agreement to what TRIPS waiver could look like. It was very narrow, relating only to vaccines, but progress on where we'd come from. All of these measures are going to need to be pulled out, and to the extent that the Commonwealth can advocate for these things, it's incredibly important that they do so.
Okay, fantastic. We all know recently there was the Commonwealth Health Ministers meeting which took place, and we saw some of the outcomes from that. And Dr. Ravi, I don't know if you would mind commenting on some of the outcomes that we read. I know you only had like a brief read of it. Perhaps some of the strengths, weaknesses, or something you felt like perhaps was missing, or you know, maybe other things that should be prioritised.
Sure. I mean, to be honest, I think like many of the comments already today, I personally tend to be very skeptical about these declarations at a high level because, in all fairness to the Commonwealth and our hosts here, the people who brought us here, those don't ultimately matter. At the end of the day, it's what happens in countries, and so it's up to people in countries to achieve change. The people outside can only help at the margin. So I think that's my initial skepticism. But then, in terms of what should the Commonwealth be doing, I mean, what's its comparative advantage even at that margin? I think the statement reflects some of the same good things, but I think one of the weaknesses in the Commonwealth, and I've been to previous health ministers' meetings and had some input in some of those declarations. I think one thing that the Commonwealth has historically failed to do, and this is on the issue of UHC, is to realize that within the Commonwealth there are these hidden stars on UHC that nobody talks about, right? I live in Southeast Asia from a WHO, that's what WHO defines as Southeast Asia. And in Southeast Asia, if people talk about who's doing well on health, and I mentioned this to Ines, I sent her a comment earlier, this email this morning, saying they always talk about Thailand, right? It's not a member of the Commonwealth, but Thailand is always mentioned. But they never mentioned the two hidden Commonwealth stars in our region. Malaysia, Sri Lanka. Sri Lanka does as well as Thailand, despite being poor, despite having a war for 40 years, despite spending less. Malaysia, okay, it's richer than Thailand, but it still does well with less health spending. Nobody talks about us. And I think that's really tragic. And I've spoken to ministers at some previous meetings with the Commonwealth, and when I talk about the value in some of these role models in our common region, Commonwealth region, they get it. It's particularly ministers from Africa, from the Caribbean, they get it. So I think one of the things that we should be talking about and are talking to ministers about is the fact that places like Malaysia, Sri Lanka, Jamaica, Hong Kong, I'm not sure, is that in the Commonwealth? I think it is, right? Or at least it participates in some of the meetings. The Commonwealth Health Association, I think, has membership from Hong Kong. But you know what I mean? These countries, and Australia to some extent, we managed to get universal health coverage without spending a great deal from government. And that's critical for developing countries because you don't have a lot of government money. And I think the ministers should be doing more to speak up the hidden golden successes in the Commonwealth. And I would urge also the Secretariat, the Commonwealth Foundation and Institute, to do much more on looking at that and spreading the word to civil society. There's a way of doing this even if you don't have a lot of money. Sorry, I took a long time. But.
No, not at all. I think that's a fantastic point. And anyone I've worked with who works in government have always said, like I said earlier, we want to hear lessons learnt from other countries. So we need to hear more from these hidden gems. And maybe, Dr. Ravi, you can tell us more about all the successes that we're having in Sri Lanka. Anyone else want to comment on the role of the Commonwealth? Perhaps anyone from the audience? Gentleman in the yellow.
Hello. Good morning, audience. This is Dr. Shruti Mahapatra. I'm from India, and I represent the Commonwealth Disabled People's Forum. And it was very interesting to hear from the panelists the word inclusivity again and again, participation of the community, and we being the agents of change. Since we are trying to build back better, and since we are thinking of spending a lot of money and resources in making the world a more sustainable place, I have a few suggestions. The first that all of us can take back from the meeting here is accessibility. You see, whether the testing centers, the quarantine centers, or the vaccination centers, none of them, most of them did not have accessibility. So many people with disabilities, they were stripped of their dignity when in the quarantine centers, they had to empty their bladders right in front of hundreds of people watching and observing them. And we need to understand that accessibility does not benefit only those with disability. So that is for all of us, the elderly, the aged, people having temporary accidents and becoming hospitalized. The second thing that we can take back from here is health partnerships at the community level. We all know that government has health workers. As in India, we have the Asha Karmis in the villages. So also we have strong communities in the villages. So if this organization of people with disabilities and the health workers, there can be a partnership, a synergy, then each and every person with disability can be identified and their needs can be taken into consideration while planning whether a relief or a rescue or a rehabilitation during a pandemic. From here, the third point that I would like to share with all of you is the heterogeneity. Unlike gender or any other issues, disability is not homogeneous. So the consideration of each and every specific disability group, be it the hearing impaired, those with blood disorders, those with autism, or with mobility impairment, these unique needs have to be considered by the planners. And this is especially for all our delegates sitting here in the front row. I would request you to kindly consider heterogeneity. Coming to the fourth point, we need budget. We know that the social sector budget is decreasing year after the year. We need more budget so that we can look at this sector, we can improve the capability of this sector, we can give them a strong voice so that many community-based people, the grassroots workers, the people who are creating successful case models can come here to these forums and share their experiences. Finally, I would like to say that today all of us here as a group must make a commitment that leave no one behind or inclusive planet. All this will become a reality when we start talking in terms at looking at the needs of the last person in the last village. Only then sustainability can be assured. Thank you.
Thank you very much.
Yeah, thanks a lot. I'm Dr. Joseph Nkurunziza. I happen to be the chairperson of the Rwanda Civil Society Platform. Yeah, I would want to, you did ask on the success story. Rwanda today has been able to provide 22.2 million doses, which counts for almost 62.8% of the entire population that has been vaccinated. So the government wouldn't have achieved that without civil society. As you might be knowing, in other countries, civil society participated in informing citizens not to get vaccinated because they won't be able to have babies. So in most countries, it happened, but in Rwanda, civil society joined hands with the government to sensitize, to create awareness, and that's why that high vaccination rate is because the civil society worked with the government. So that's a success story of how civil society can be able to partner with the government to address health issues. I think it's Professor Feza? Yeah, thank you, I'm sorry. She did mention that there's a need to strengthen local civil societies whereby bilateral donors providing resources so as to be able to build the capacities of the local people. But I think what the Commonwealth can do is to try and bring together Commonwealth nations to understand that they need to fund their civil societies, because we receive resources from bilateral donors. So when it comes to address critical issues around the rights of the LGBT, safe abortion, contraceptives, governments, which you know, get those civil societies and tell them, you're spreading Western agenda. This is not our agenda. So I think the Commonwealth needs to bring Commonwealth nations to understand that as we are advocating to increase budget for health, they also need to increase the resources for civil society so that civil society can be able to be strong, to have effectiveness, strong people, to be able to hold governments accountable. Thank you.
Thank you. Thank you very much. I'm going to come back to questions in the audience in a minute. I just wanted to go back to our panel briefly and ask one more question. So the role of the Commonwealth in championing health as a human right, and ensuring that we leave no one behind to ensure that health system strengthening is adequately addressed to reach all people within a country's borders. I want to know if there's anyone on the panel, anyone who'd like to answer a bit more about what the role the Commonwealth can play in championing health as a human right. Any comments on that? Professor?
I'm happy to come in. I think a lot has been said already, especially with points that were raised from the panel. I am with Ravi that while global mechanisms are amazing for building an agenda, setting advocacy, setting goals, at the end of the day, where the rubber hits, the road is at the country level. But having said that, the Commonwealth is an incredible platform of 54 countries where policy can be designed, especially with all the issues we heard. Our friend from India sent us, she gave us 5 succinct points to take home and talk about. I had looked at the ministerial declaration, and while I applaud the ministers for highlighting issues that we are grappling with, whether it's vaccine inequity or strengthening health systems, a lot of the issues that were raised in this room were not included. What does it mean to deal with people with disability? We heard about the heterogeneity, the need. How does that translate? How do you translate policy into action? Because at the end of the day, you can have all the policies in the world, which we do, but we don't implement them, right? So what happens is we end up pushing the goalpost. There are MDGs, we made some gains, then we go to SDGs. We have, now we have a setback of COVID. So I think a lot of this is to say, how do we operationalize? So I think I really like the public leadership idea. Ravi's idea of looking at success stories. I always say in this continent we are cursed. When somebody wants to see an example, they want to go to Europe or US, whereas there are incredible examples, whether it's for training, whether it is for essential health services of countries that are similar in terms of size or budget or growth or GDP that we can learn from. So what are the best examples within the Commonwealth that we can look at? I mean, despite the setback of the last few years, Ethiopia has done enormously well through community health workers to reach MDG goals on reducing maternal mortality and reducing child mortality. So I think the Commonwealth can play a pivotal role in policy and advocacy, as well as ensuring that all the issues that were raised here are included, as well as creating opportunities for shared experiences.
Yeah. And I'd even go as far as to say that some of the mistakes that we made, perhaps in the West, in my country, in the UK, for example, are because there was a reluctance to listen to some of the lessons learned from past pandemics in other countries, perhaps not as developed. So I think that's a really, really important point. Just very lastly, because one of the problems, and when I was reading the minister's brief and the outcomes, one of the problems I felt with it is that we're always trying to tackle too much. Universal healthcare coverage, it's got to cover everything. We talked about social determinants, and the problem that sometimes I find of all of these issues is it's hard to prioritize. So it's a difficult question, and I don't think we'll come to an answer to it in this particular session, but any thoughts on like how we can better prioritize so that, you know, we can actually realize some of these, some good outcomes? I don't know, Justin, if you'd like to comment.
I mean, it is a really tricky question, and when people agree to UHC, often the next question is, okay, what do I do next? Because it is so vast, and it's also so dependent on country context. But one general thing that I think you can say is that the best bang for your buck is primary healthcare. There's no use spending zillions of dollars on expensive tertiary hospitals when the mother has to walk 10 kilometers to go to the health center when her child has diarrhea. I think that the framework that we're using is that in order to achieve both global health security and universal health coverage, which, as Professor Senate said, are really two sides of the same coin, you really need them both. The means is health system strengthening, and the approach is primary healthcare. And I think that's what we should be emphasizing in all declarations and in all action.
Thank you. Okay, I'll go back to our audience, and I just want to ask if you please raise your hand if you have a question for our panelists, and then we can take any statements a bit later on. So questions. So I'm just trying to see if there's anyone in the back that I've missed. I think Madihi said there was a man in a white shirt who I couldn't see.
Thanks very much. I'm Owen Tudor. I'm convener of the Commonwealth Trade Union Group, which represents 70 million trade unionists around the world. I wanted partly also to draw on some of the other things that you asked about successes of civil society working with governments and employers, and also some of the things that the Commonwealth needed to do in terms of establishing human rights. 11 days ago, and this takes a slightly wider definition of universal health coverage from some of the ones that people have been referring to, because I think it also needs to look at things like universal social protection and in particular health in the workplace. The International Labour Organization 11 days ago agreed to a trade union request with the backing of governments and employers from all of its 187 countries to recognize the right to a healthy and safe working environment as a fundamental principle and right at work. And that goes wider than just workers. It applies, because working environments are hospitals, they're care homes, they're schools, they're places like this, restaurants, buses, all of those areas. So, however, as Ravi said, the critical issue is how you actually implement that right, and how you get the 187 governments that signed up to that right 11 days ago to actually ratify and then implement things like Convention 155 of the ILO on occupational safety and health. And in terms of what the Commonwealth can do, barely a third of Commonwealth countries have ratified Convention 155. Fewer even have implemented it. This will be critical to making sure that people who go to workplaces, not just go to work, but go to workplaces, are kept healthy and safe. And it would be really useful to hear from the panel about what they think can be done by the Commonwealth to make sure that that number of Commonwealth governments which have ratified and implemented those conventions and other conventions that apply to this are implemented. I like Ravi's idea of a wealth tax. Not particularly surprising from a trade unionist, obviously, but that would certainly be worth doing, and we need to make sure that these things are done in workplaces around the world. Thank you.
Thank you very much. Dr. Ravi, would you like to comment?
Yeah, I mean, as I said before, I think these functions, these high-level declarations, have some value, I think, in normalizing, legitimizing the importance of certain ideas, and I'm not going to dismiss that. It's important. Hopefully many of you, all of us, will go back to our countries with a bit more energy and a bit more motivation to fight for some of those things, so that's a great thing. But ultimately the struggle is in countries. And on the issue of health as a human right, my kind of view is, there are countries that put that in their constitution, and it means nothing. Sri Lanka doesn't have it in its constitution. We were at least the people who designed our original constitution were a bit smarter. They just insisted we should have accountable government, representative government. So I think we should talk about health as a human right. We should talk about these conventions and those other things. Sri Lanka is one of those countries that hasn't ratified all the ILO conventions either. So this is, a democratic deficit, I think. But remember that health is a human right. Why is it a human right? It's a human right because we as individual human beings value health, right? That's why it's a human right. It's not some artificial thing from somebody else. It's because we're human beings. It's important to us. Social protection is important to us. I think even this issue of solidarity and loving thy neighbor, and I put my medical hat on, the scientific evidence is that humans, we're hardwired to care about other human beings. So this reflects our humanity. So I think what we need to do is not just have those legalistic concepts. We need to, and the Commonwealth needs to focus on its work in supporting democratic life and strengthening the quality of democratic life, and that's really the most important thing. And then just on a policy issue, on the issue of taxation, because ministers come to the meetings, right? Probably a lot of people at the high level come to these meetings, right, in Kigali this week or next week. And one of the reasons we don't have enough taxes is because the elite in many countries, and this is an issue of global thinking, have thought wrongly the only way to get faster economic growth is through lower taxes. They forget about Germany and Sweden and all these other countries with high taxation who are doing quite well. Or Singapore even actually has very high taxation. And so I think it's useful at the high level maybe to get the ministers to understand the importance of taxation as a basis for realizing all the other promises that they're making, including the Abuja Declaration, which was basically ignored in practice. Thank you.
Round of applause. Any more questions? Gentleman in the front.
Thank you very much. My name is Dr. Osahon Inabulele. I'm the president of the Commonwealth Medical Association and the president-elect of the World Medical Association. I just want to say that it's been a very exhilarating session, and I thank you for recognizing me at last.
Sorry.
I think the key issues have been distilled. I think fundamentally what we have learned in the COVID era is the fact that leadership, governance, and political commitment is very key. Also key is the issue of the people. Because part of the learning point was that trust was vital. A lot of what you saw as apathy to vaccination in some countries was because of the distrust of the government. Yeah. You say one thing and do another thing. Yeah. And so the people lost trust. So even in the conversations for health system building and resilience, the people's participation, how to galvanize them and get their trust is very critical, as much as engaging the governments in terms of driving more political commitments. And the critical question, therefore, is how do we drive that commitment? I think civil society must leave the realm of staying in the trenches, because we've stayed in the trenches for too long in terms of these eternal conversations, lobbying, engaging, because the politicians do not believe in all those things, largely. They only believe when it has to affect their votes in terms of their electoral dispositions. And so you see them building hospitals when the elections are coming, especially in some low middle income countries, including countries of Africa. So I think that one of the things that civil society must begin to deal with is how to really engage in the political process. Because they only can transform you into what I call sorry appendages or sham reformism. Unless and until you get involved in the political process, even as civil society, we'll continue to sit around tables and begin to look up there for some of this support to come to us without really achieving the end results. So what some civil societies are doing, including professional organizations, is now empowering themselves to enlist members, even in the political parties, in the political process, and through them be able to more realistically and pragmatically achieve some of those goals, rather than everyday lobbying, engaging. That is a long, arduous, and tortuous path. And I do not say it doesn't achieve anything, but let's understand that politics is everything. And we must also engage in that process as civil society. Therefore, in terms of what the Commonwealth should do, Commonwealth must necessarily, with due respect, also begin to empower civil society and even the health professional organizations under the Commonwealth. I've raised the issue, for instance, why Commonwealth organizations are not supported anymore. How do Commonwealth organizations engage governments in this laborious process without empowerment? How many civil societies are here? So Commonwealth must set aside funds to empower the process, empower organizations to be able to engage even at localities. I therefore want to also see that, look, that empowerment must also involve having a carrot and stick approach to governance. How does Commonwealth come together every time? We present papers, engage in talks, almost looking like a talk about talks. Is there a carrot and stick approach that we can use to get governments in line?
Yeah.
Are there ranking mechanisms, for instance, to shame governments who are not performing?
Yeah.
Even as we applaud Malaysia, Sri Lanka, and others that have been deemed to be performing. So we must get serious in terms of enthroning good governance in most of these countries, in terms of driving good leadership and improving political commitment. One of the lessons COVID told us was that if really you have political commitment, a lot of things can happen. For the first time, we saw governments, especially in Africa, staying in their countries and not flying for health tourism. But soon after the gates were thrown open, you saw them junketing around looking for how to cater for their health needs and abandoning local resources. So how do we plug those kind of wastages? Unbridled capital flights. So I therefore say that a lot has to do with pragmatic, scalable, actionable agenda, which we can, of course, derive from conversations like this, but not an eternal conversation. We must be able to walk the talk and get governments to be a bit more responsible, in terms of attending to the needs. Look at human resource for health. Nobody cares about human resource for health in most of these countries. And I dare say, beyond PAC, the human resource for health is also a linchpin of the health system, building processes. A lot of African health workers are being pushed by countries in the global north, in spite of the WHO global code. What are we doing about it? How are we empowering or stopping this kind of unbridled poaching of human resource for health in countries that best need human resource for health? Okay. Today, as I speak to you, Africa has less than 3% of the global health workforce, but in spite of that, they constitute about 25% of the disease burden of the world. And so are in more demand of human resource for health. But every day, even in COVID, it looks like we are all looking at workers coming from these countries where they're supposed to need more, going elsewhere because of the failure of governments in the source countries to provide for their needs. So how do we cater for human resource for health in terms of empowering them to be part of this whole process of strengthening health systems in our countries? After all, it's one of the building blocks of health system development. But we cannot continue to pay lip service to their motivation, to their welfare, and of course to their empowerment. I will stop at this for now, but let me say that citizens' participation is key. I've talked about it before, and we must be very, very critical about this. I thank you very much for this opportunity.
Thank you very much. I don't know if anyone from the Commonwealth Foundation wants to comment on any type of work that's been done on mentorship or getting people involved in the political process. I don't want to put anyone on the spot, but if anyone wants to comment. Yeah? Okay. All right. Thank you. Ravi, do you want to comment?
Sure.
On that.
Okay, go ahead. Yeah? Okay, so thank you. I didn't catch your name, sir, but I believe you're from Nigeria because the head of the Commonwealth Association, the Medical Association, is, I know, Nigerian. I just wanted to just it reminds me of something about Nigeria, and I thought it may be just useful to share. You made a very important point, which was you have to persuade politicians that it's in their own interest in terms of getting votes, right? Because even if politicians are corrupt, if you want to be corrupt, you still have to win an election, right, to make the money. So winning elections is important. And the reason I was so excited about it, really struck by that, I just published a paper about 2 weeks ago on its financing malaria, so it's not really on this. But I was looking at Nigeria because one of the things we were looking at in our research was the issue of West Africa, where the burden of malaria is worst, and what are the differences with places like Sri Lanka historically, China, which eliminated malaria. And one of the big differences was that in Sri Lanka, we didn't put so much emphasis on bed nets and all this other kind of stuff. Insecticides failed us. The main reason for our success was that we made sure everyone with a fever got treatment. They could get to the clinic and they got treated. And in much of West Africa, including Nigeria, if you have a fever, you don't get treated. You don't get the antimalarials. But the donors are pushing bed nets and all sorts of other fancy stuff, but they don't deal with the fundamental issue of healthcare access. Now, the funny thing is, in Nigeria, the opinion polls I found show voters rank health as the most important issue. And so the question, and there's also evidence, there's a study in Nigeria showing that politicians who did more for health got more votes. The question is, why don't the politicians know this? And I think this is where the Commonwealth has a role, because it's not just about voting structures, it's about ideas. And I think politicians in many places don't understand that responding to people's needs, providing basic health care, is a vote winner. And I think that message needs to be got across. There are plenty of examples in the Commonwealth where that's happened, and that's one thing I think the Commonwealth can do at the level of political leaders. Sorry, I took your time.
No, thank you very much. We've got one last question here, and then we need to wrap up.
Yeah, we have Samuel Manana, who has a general comment, but he's going to sign his comment and it'll be translated at the back.
Thank you very much.
Yes. You need me to focus here or in the front? Yeah, of course, in the front. Yes, thank you. Yes, I'm seeing there on the screen. Good morning, all. My name is Samuel. I'm Executive Director of Rwanda National Union of the Deaf. I'm really happy to be here. I just to give the general comment. All the presentation here, they are really great. Here in the law, we are talking about health in general. Yeah, that's true. But I think we have to think about the inclusive health system. Because sometimes the communication is somehow really very challenging in health system. Here I'm mentioning about people with a disability. For example, we think in general, but forgetting these people with challenges. People with disabilities, they're hidden in their family. It means that if they're hidden in their respective families, they are not even included in the system, that we are talking about. So if they are there in their respective families, we need to think strategically on how to bring them on board. Second, program designing and implementation. This is the key. We have to think before, when you are designing the programs, think on how it can be inclusive, especially for the most challenged or face people who are left behind. Because we have to always think not leave anyone behind. This is about accessibility in health service delivery. Some mentioned about that one. But maybe sometimes when we talk about persons with disabilities, we normally talk about physical accessibilities only. When we talk about health services, we talk about wheelchairs, ramp but we forget about communication for persons with hearing impairment. They need to access to the health, to the health services in terms doctors. You know, health is this didn't be private, and I'm going to the hospital. I need to talk to the doctors, and I need an interpreter. Why not think about the health services providers to be accessible for persons with hearing impairment and others with other difficulties. So I think we should look during coming years to look at persons with disabilities in general. Thank you.
Thank you very much, and thank you for all of your participation, all your questions. Obviously, the conversation could continue for so much longer, but I'm afraid we have to wrap up. And I'd like to really thank our esteemed panel for answering all the questions. A wonderful, wonderful conversation. We've heard something about lessons from the pandemic and how our global system is failing us and has failed us throughout the pandemic to deliver to the people. We've heard also some great success stories from many countries and how the importance of having to share them across the Commonwealth and in other fora as well. And I think the real heart of this session has been the discussion about civil society and the importance of actually having representation from different groups, people, I guess, with less power, the most important thing, and the importance of public leadership as well, very, very specifically, and the issue of distrust in government and holding our governments to account, very, very important as well, and in all the different things that the Commonwealth can do, especially in convening these various different groups, prioritizing different topics such as, financing, or making sure that there's room for mentorship and so people can take part in the political process, all these different views. And I know I haven't summarized everything, but it was a fantastic session. So thank you very much for your time. Thanks for having us.
One more round of applause for Dr. Inez and her panel.